conclude by telling you on the recent European Society of Hypertension 2023 guidelines on the management of hypertension. So step one is ACE or ARB and calcium channel blockers. You add a diuretic. In a true resistant hypertension, one has to rule out secondary cause of hypertension, like a pheochromocytoma or a coarctation of aorta or an adrenal tumor or a pituitary tumor, and all secondary causes of hypertension have to be ruled out. And if they are ruled out and it is still resistant hypertension, then one can even add a triple therapy, and beta blocker can be added also as a monotherapy. Now, in the second and the third stage, when we look at calcium channel blockers, yes, we used amlodipine all our lives. But in the last 8 years, we realized that cilnidipine made a difference to control the blood pressure in these patients. And I'm really talking about my true world practice. I'm not talking just theory or just these slides have been given to me, meaning I believe in this. And I've seen it in my day-to-day practice, how cilnidipine makes a difference to control our blood pressure and protect target organ damage. I've been working very hard on heart failure, and we are creating our own LVAD devices for heart failure now. But I realize that all hypertensive advanced heart failure patients, to prevent tachycardia and to protect their kidneys, I prefer to use cilnidipine. So they have become integral part of the hypertensive management in CKD patients. This, I think, is renoprotective benefits, and younger patients with sympathetic overdrive. Most global guidelines are now generating fourth generation calcium channel blockers, and this is gaining cilnidipine widespread recognition with a lot of studies now. Until 2022-23, we have studies on cilnidipine, sympatho, lytic, and renoprotective effects. So these are the ideal patients who can be on cilnidipine, newly diagnosed hypertensive, those who are not controlled on the ARB monotherapy, those who have comorbid diabetes, those who have a mild to moderate renal impairment, those are not tolerating amlodipine due to reflex tachycardia, sympathetic overactivity, and pedal edema, and uncontrolled hypertensive patients on amlodipine with ARB. You can stop the amlodipine and put them on cilnidipine, and you will see the difference. I'll just conclude by showing you 2-3 cases which I pulled only yesterday evening when I came to Oman today morning. I'm leaving tomorrow early morning. So from our cath lab, I just picked up a few cases of hypertension where we had used cilnidipine. So I asked my team if they can plug in few cases of where we have used cilnidipine. So this was a 75-year-old patient, resistant hypertension with bilateral renal artery stenosis. We did a stenting of both the renal arteries, and now she's well controlled on cilnidipine and diuretics. Until last 2 months, she's only on cilnidipine, 10 milligram with control of blood pressure. So this is the left renal artery with a tight stenosis. Put in a BMW wire, dilated with a balloon, and then put this Abedka hippocampus stent in the ostium of the renal artery and the proximal segment, and that was the final result. If you look at the right renal artery, she also has a tight stenosis in the right renal artery, and this is a balloon dilatation with the right renal artery and a stent deployed. So bilateral renal artery stenosis, resistant hypertension, and now on an OD 10 milligram dose of cilnidipine. This is a 70-year-old male patient, heart failure, hypertension, CKD, dilated cardiomyopathy, EF 20%. We treated him with a combo device, which is CRT with ICD. Presently, he's on class 1 symptoms on ARNI, cilnidipine, and ivabradine. I know ARNI is not recommended for hypertension, but some of our resistant hypertension with advanced heart failure have been using ARNI, which gives a good control of blood pressure. It's available as Vimeda in India, still here. And we find that in heart failure patients with hypertension, ARNI with cilnidipine is an off-label indication of use of ARNI and cilnidipine both. But in day-to-day practice, we find this to be useful. So this is a CRT device where we put a catheter in the carotid sinus, in the coronary sinus, and then there is a lead in the RA, RV, and in the LV through the coronary sinus to pace the left ventricle, so that there is synchrony between the two ventricles, which will allow septal participation to improve the cardiac index.